So we're going to go back now to where we started with traumatic brain injury. And Nicole von Stienbüchel-Rheinwall, I'm sure I haven't pronounced that entirely correctly, who's director of the Department of Medical Physiology, Psychology and Sociology at the University of Göttingen, talking about the quality of life after traumatic brain injury from an international perspective. My bet is it's not very good.
You'll see. Yeah. Here I am. Parallel processing starts to be difficult. Thank you so much for having me here. Thank you to the students and to Verity. It's a great pleasure. I've learned a lot today, and I enjoy St. Andrews. I will talk about a collaborative group as well now on quality of life after traumatic brain injury. And as you can see on this slide already, many people working together. You can learn a lot about different nations, different professions, and different personalities if you cooperate. Sometimes it's difficult, sometimes it was rough. It was like a collaboration of 12 years, but we ended up with an instrument what we now think is usable in many different contexts with patients with traumatic brain injury, but also then later probably in patients with a stroke and other central nervous system diseases. I've actually started out with neuropsychological research rather basically, and when Mark talked, I remembered all these discussions on classification of neuropsychological functions, which is never ending and still, I think, is not clear. I mean, you have 10 people and 10 people have different ideas of which dimensions and tests are really necessary, and if you end up with your group in having solid and valid tests, I'll be very happy to. What you're seeing here is on the left side the traditional outcome we are measuring. This is always why I'm going to talk last mostly. The medical outcome endpoints we know, for example, in traumatic brain injury, used to be survival in years, used to be neuropsychological tests. MRI is coming up. There are new studies now showing that even in patients with mild traumatic brain injury, if you look at early MRI results of 3 weeks and then being followed by or combined with neuropsychological testing, that you see problems in these patients. These are results not yet published by Jeff Manley, and I think this is impressive because usually people say, no, it doesn't make a difference, don't do it, it's expensive. Yes, it's expensive, but I think it's worthwhile because if people with these mild traumatic brain injuries, they do suffer from a lot of problems and they are just let out without any treatment, and I think we have to do something there. There are moderators for quality of life and outcome, which are social support, life events. I'm very happy that Don talked about PTSD because it's still not only neglected by doctors but also by neurosurgeons, and it is something which is not so easy to be defined, but there is something there, and I think it's really necessary to assess. Anxiety and depression is very important, not only in patients or people after traumatic brain injury, but in practically all problems and diseases you have, there's a great correlation between quality of life and anxiety and depression. If we're looking at the right side now, at the patient-rated outcomes, or the patient-related outcome, I think Mark noted down there. Their subjective health is one of the main variables measured. I see a slight difference between subjective health and subjective health-related quality of life. In quality of life, you would ask for issues of autonomy, expectancies, to live up to expectancies. If you ask yourself, what is your quality of life about? What is important for you for your quality of life? You'll come up with some ideas right now. It can be life satisfaction. It can be very different for us, but there are dimensions which are very comparable. The content may be different, but the dimensions are comparable. We measured quality of life in a generic way. So like this, you can compare different diseases, patients with different diseases. And there's another way of measuring it, specifically, or disease specifically. There you have the possibility to really get into the specific consequences of a disease or a problem or an infection or therapy or whatever, though you cannot compare this condition with others. So there are pros and cons for using either generic instruments or specific. And you'll hopefully get not a full picture, but a fuller picture than what we have now. Monika Bullinger and myself came up with, already in the 80s, with a definition on quality of life. For us, quality of life is a multidimensional construct that comprises the physical domain, the psychological domain, the social domain, and daily life components. And I would really like to have you observe this, the mental component, because usually in the definitions which are around, it's only the emotional component which is measured and assessed by the psychological and meant by the psychological domain. And obviously, me coming from neuropsychology, I think the cognitive mental domain is at least as important. Now, being very close, or I've worked in Alzheimer's for a long time in Geneva, and there you learn how important the emotional domain is, because when you lose cognition, you have only emotions to orientate yourself, which still gets you a long way. But so I think both is important. How do we try to measure this quality of life construct? By well-being, subjective well-being, and functioning from the patient's perspective. And only if the patient cannot answer anymore, then it would be the observer's perspective. In lethal diseases and religious and spiritual aspects get very important, and as you can imagine, there is not one questionnaire for spiritual and religious aspects now, because there are whole wars going on because of that. So if we look at the next slide, quality of life, when I've started working in the field of quality of life, I've started with epilepsy research. There were 60 papers around with the topic. Now there are 170,000 and more. There were about, I don't remember, maybe 800 on traumatic brain injury, and now we have over 60,000, and on quality of life and traumatic brain injury there are around 950. That increased tremendously in the last, I would say, 10 years. The traditional outcomes focuses are functional outcome, return to work, productivity. Recovery is measured by the GOS, Glasgow Outcome Scale, or the GOSE, which is an extended form of the GOS, and the most frequently measured subjective health measure. It's called quality of life measure, but I would say there's a slight difference. For me, a real quality of life measure is much more getting the psychological aspects of well-being than only health. But it's a very well tested and used questionnaire, and I think we should always combine it. There was no disease-specific instrument when we were starting the cooperation in the field of traumatic brain injury, and we started to get into a collaboration to develop this questionnaire called QOLIBRI, Quality of Life After Brain Injury. And how did we develop and measure it? We certainly used clinical data. I will not take you through the whole protocol. We used a recovery measure, the GOSE. We used generic health quality of life measure, the SF36. And we developed this quality of life after brain injury instrument called QOLIBRI, or as the English-speaking would say, QOLIBRI, but QOLIBRI in Latin in these Latin-speaking and German-speaking languages would be a hummingbird. So it works for some countries, it doesn't work in English. QOLIBRI and the QOLIBRI OS, which is the overall screener, a small scale of 6 items, which you would use to screen, or where you have a patient who is really very still can't be attentive and is very sick. You would use the short one. I will not get in the whole development, but we tried to develop this instrument consensually. So we had all different countries already working together in the very beginning in a cross-cultural approach. We had a multidisciplinary cooperation, which was important. And here you see the original countries who started to develop. Actually, there was somebody from Brazil, in Lucia Braga, which was very important for us, because we had some example questions asking, how satisfied are you with your capability to read, or your ability to read? Well, Lucia raised her arm and said, well, most of our patients don't read, they can't read. So important for us to develop our questions. So we have mostly questions which are not asking for deficits but positive aspects, or which are important to the patients. And then there were some questions asking, how bothered are you by a problem of impulsivity, for example. Item examples. Examples of the overall screener I'm showing you because they are representative for the other subscales we are using in the long form. So we have a subscale on physical functioning and well-being. We have a subscale which is different than most other scales, which is tackling the neuropsychological and cognitive aspects. We have a subscale assessing feelings and emotions and daily living here, and also an aspect which is really important for these patients, current situation and future aspects or prospects, because what you can think when somebody had a traumatic brain injury, life can be shattered and people cannot get back to the situation they were before. Marriage, after 2-3 years, marriages are breaking up because the partners realize, I don't have the same partner than before and cannot adapt to it. And, well, really sad and difficult. And I hope through the progesterone maybe we'll have less of these patients. We performed 2 studies. One, the first developmental study, we had 1,528 people. In the second, we had 928 or 21. I will only show you now data on the quality of life questionnaire with the GCS, the Glasgow Coma Scale, and the recovery scale, the GOSE, because that's how you publish. And so the patients we had here, or the people we had here, were about 40 years old, ranged from 17 to 68. As Don showed, 70% 2 male, 28 female. Glasgow Coma Scale, around 60% severe, 10% moderate, and 35 mild or 2 mild. I have to tell you that only 2 countries performed consecutive recruitment of patients. This was Germany and Australia. All the other centers recruited in convenience samples, so in rehab centers mostly. And this is due to the fact that the people who took part in the study was not financed. So you have to think about people working really because they were interested in the topic and they thought it is needed. This to develop a tool is really needed in the field, so we got together to develop that. The methodological aspects were funded mostly by the universities. I was working in Geneva and then now Göttingen, and they come together by George Sidney, who thought that this was something important. So in the beginning we could meet, and the meetings were financed, but besides that, nothing. So I think it was really a great endeavor, and if you want something, you can do it. I mean, I'm not Obama. I don't think you can do everything, but I think, I would like to get this over to you that we can. Coma length and post-traumatic post-traumatic amnesia are much more difficult to measure, and I would not go into this. So what we saw before, 20% with severe disability on the GOSE, 50% with moderate disability, and 30% with good recovery in our group. You all know the hospital anxiety depression scale probably. You have a group of people being anxious, only 6%, but moderately anxious and depressed, 13%, 18% mild. And the rest, 63 or 68, not anxious and not depressed in our group. Obviously, as the people had to be able to answer to these questionnaires, they were not in coma or that disabled, but still we had 60% is very severely impaired. Here you have the questionnaire. This is the short one, the overall screener. You have the cognition subscale, self subscale, daily life and autonomy, social life, negative feelings. So this was how satisfied are you with, and this is how bothered are you with, physical problems. And this is a total scale, the QOLIBRI total, which is helpful if you want to aggregate scores, for example. This is not a very usual way to depict Cronbach's alpha. You all know what Cronbach's alpha is. Reliability, if you look on that in all countries, most of the countries are above 0.8, which is good and which allows you to make good comparisons between groups. And if you look at the QOLIBRI total sum score, this is actually for all countries above 90, which is then enables you also to compare patients on an individual basis. There are some countries, but Holland, for example, has less people in there, which are not living up to the criteria, but that's how it is. Here we have a subsample of people with low cognitive performance and high cognitive performance, looking at the reliability, because obviously people who are rather opposed to assessing in subjective well-being aspects, there are still people saying, well, you cannot measure it, it's too complex, no possibility to do that. And an argument in the traumatic brain injury field was that, well, people cannot understand what you're asking there. Obviously, it's really important to formulate the question simple and with not too much information in it. Like the SF-36 is much more complex or more complex than our questions. And, well, we had, this is a subsample because we only in Germany and one more country we looked at the mini-mental state examination. So what you can see, the Cronbach's alpha or the reliability is not that different, and it's first measurement, second measurement, the retest reliability goes a little down in these patient groups, but it's good. I would like now to show you our validity analysis and relationships between QOLIBRI and demographic, comorbidity, emotional state, and disability. And I thank Mark for starting to talk about psychometrics before. So what I would like to do now, I would like to take you through the following slides rather quickly because they are all set up in the same way. Here you have 0 quality of life, 100% quality of life, and here you will always see the different subscales. So the overall scale, the total scale, and the subscales. And what you can see here is that people living independently are better off than people living in a supported home or at home, still with their significant others. But people living in a sheltered home seem to have a better quality of life. So this could be either due to that they feel more secure, or that they have a greater anosognosia, so some kind of, I wouldn't call it denial. Many people call anosognosia denial of the problems, but I would say they don't have an insight because of their brain lesion in what happened to them. So it could be both. We measured anosognosia in our group in Germany, and there is a correlation between quality of life in people who are really highly anosognotic, do have a better quality of life. And I already recognized that in a big WHO study I performed in Geneva in Alzheimer's patients. So, yeah. Relationship with comorbidity and quality of life, very few health problems, much better quality of life than 7 and more health problems, headache and migraine, and now the next ones will be like that. People with no problem and people with the problem. So people with no headache, and in all scales you will see that it differentiates. Nervousness the same. Lack of energy, so mental fatigue, which is really very prominent in patients with or people after traumatic brain injury. Lack of physical strength, always much better off if they don't have it than have it. So this shows that the scale is differentiating. In communication problems, attention function or dysfunctioning, people without have a better quality of life than with. Memory dysfunction, same. Executive function disorders, also, they do have a better quality of life if they don't have it and they realize it. If you look at psychiatric disorder problems, there's a big correlation, and especially in depression and quality of life in traumatic brain injury. And so here we have a more general question for affective disorders. For all subscales, you have a strong difference in people with and without problems. And here is again the heads. You see people under the threshold, the quality of life, people with anxiety only, people with depression only. The different colors are different subscales. And if patients have a dual diagnosis of anxiety and depression, which is really obvious, is that the experience of self-identity, self-awareness is really very low. So this means a lot of work can be done there therapeutically, combined with if we have any treatment, but also psychotherapeutically. Social participation is immensely important for all of us, but yes, also for patients with traumatic brain injury. And if you see people without, do have a less good quality of life than people who are integrated. Same thing is with employment. This is why we try to get people back to work as well, but they never, or people who have a rather bad traumatic brain injury are mostly working in a much simpler situation, like trying to answer telephones instead of being a project manager, for example. And same thing here, yes, for all scales, we have a difference for the patients. Daily living difference also to what we measured was personal, basic personal needs, basic mobility, daily activity. How long do I still have? Transportation and organization. How many?
5 minutes.
Okay, I can do it. And what you can see here is people with none, much better quality of life than people with more than one problem. And the GOSE, which you saw before, people with severe disability, much worse quality of life than with good recovery. And I would just like to show you these two examples because I think it shows the value. It's really just exemplary. You have two people with a GOSE of 5. It goes from 1 to 8. And there's one person with a very high quality of life, and you can have somebody with a GOSE of 5 with not that good of a GOSE and quality of life. You have a person with a GOSE of 3 and a person with a GOS3 of 8. So somebody with a very bad outcome, functional outcome, recovery outcome, somebody with a very good outcome, and the person with a good GOSE outcome has a low quality of life, and somebody with a very bad outcome in the GOSE can have a good outcome and quality of life. This is just to make an example that it's important to associate functional measures like, for example, the GOSE with subjective measures as the quality of life measure if you want to treat the person adequately. Well, I think I will skip this slide and just tell you that we made a analysis regression model for the total QOLIBRI scale, and our model could explain 58% of the variance, and the main correlates of quality of life in our study were emotional states, so depression and anxiety, then the GOSE and the help needed, disability, and comorbid health. Summary is that yes, we have a first disease-specific quality of life tool now. We have a nice website. If you're interested going on that, it's www.qolibrinet.com. And there are about 180 studies now likely to use the QOLIBRI, if we can believe in our in the website. And I think it's important to say, yes, it's influenced by functional quality of life, it's influenced by a functional status, but it's distinct from it. It is related strongly to mood, as in many different diseases as well, but it really adds information, and it really also adds information which is not picked up in the SF36. I didn't get into that, but yeah, I think so. It's much more specific. What we want to do is just look at these three. We are going on with validation, and we are finished with validation and sensitivity studies. Intervention studies would be great. So this is again, and I try to address Dawn to if there are further studies with progesterone to put the questionnaire in. And we are just developing a proxy version for the people who are really severely impaired. This is on the way. And then there are statistical aspects we are tackling now, the first two. The children's version is still very far away from being ready, but we started. Thank you very much.
Good. Thank you very much, Nicole.